Hey everyone, and welcome to this explainer. Look, if you're tracking the big, fundamental shifts happening right now in gastrointestinal medicine, you are in exactly the right place today. We're going to dig into a medical mystery that's essentially been hiding in plain sight. We are talking about the modern paradigm of GERD management. Now, GERD, or gastroesophageal reflux disease, is incredibly common. You're going to see it constantly in both surgical and GI practices. It's quite literally everywhere. But as we're going to see, the way the medical community has historically handled it, well, it's actually created a massive clinical blind spot. So, let's jump right in. Our source material hits us right away with this completely stark paradox. Indiscriminate empiric treatment has led to overdiagnosis. Now, just as a refresher, empiric treatment basically means treating a patient based on a clinical hunch or just their symptoms without any objective confirmation. And for decades, this primary method for dealing with GRD symptoms has acted as a giant clinical trap. We honestly thought we were curing patients, but in a ton of cases, we were really just masking the underlying problem or, creating entirely new ones.
Okay, so part one, the acid suppressant trap. To figure out how we get out of this mess, we kind of need to see how we fell into it in the first place.
Think about it from the clinic's perspective. A patient walks in, and they've got this overwhelming variety of symptoms, right? Heartburn, regurgitation, chest discomfort. But then it branches out into a chronic cough, throat symptoms, and just a whole host of stubborn, refractory upper GI complaints. These symptoms are everywhere, and they are deeply uncomfortable. So naturally, clinicians want to provide a fast, effective solution. They just want to help the patient get immediate relief.
And historically, that fast, reflex-like solution has been proton pump inhibitors, good old PPIs. They have absolutely been the cornerstone of therapy. And honestly, on the surface, it makes total sense. A patient complains of burning in their chest or throat, you assume it's stomach acid, and boom, you prescribe a medication designed to suppress that acid. It basically became the default blunt instrument for any upper GI complaint that vaguely resembled reflux.
But here is where the plot twists. This well-intentioned empiric approach completely backfired, and it left us with three major consequences. First up, overdiagnosis. Suddenly, everyone with a slight cough or a little heartburn got slapped with a GERD label. Second, prolonged unnecessary medication use. Guys, we're talking about patients taking daily acid suppressants for years, literally decades, without ever actually needing them. And third, and this is arguably the most dangerous, the absolute failure to recognize functional esophageal disorders. By throwing a giant blanket of acid suppression over every single symptom, we completely blinded ourselves to what was actually happening to a huge chunk of these patients. Which brings us to part two, identifying the true imposters. If it isn't GERD, then what the heck is it? Let's take a look. We really need to lock in on this definition. Functional esophageal disorders are conditions that present with symptoms mimicking GERD, so the patient absolutely feels the heartburn or the chest discomfort, but, and this is crucial, they occur entirely without true pathologic reflux. There's zero excess acid washing up and damaging the esophagus. The pain is real, for sure, but the biological mechanism is totally different. And these are the exact conditions we completely miss when we just blindly hand out acid suppressants. So who are these mimics? Well, we've got reflux hypersensitivity, where just normal, everyday levels of acid trigger extreme pain. There's functional heartburn, rumination syndrome, and motility disorders, which is where the issue is actually about how the esophagus physically moves and clears food, nothing to do with the acid itself. If you're relying purely on a symptom-based, PPI-heavy approach, you are going to miss every single one of these specific disorders, literally all of them. I really want to slow down and hammer this point home because it's that important. Escalating acid suppression in patients without pathologic reflux offers little benefit. Actually, scratch that, it's a completely terrible strategy. Imagine someone with a motility disorder. Their esophagus isn't squeezing right, so they have chest pain. The doctor assumes it's GERD, writes a script for a PPI. Obviously, the pain doesn't go away. The old instinct was just to double the dose, right? Go stronger. But ramping up acid meds for these imposters doesn't help the patient at all. It just exposes them to the side effects of long-term meds while their actual disease sits there totally untreated. All right, part three, the modern clinical algorithm. Thankfully, medicine is constantly evolving, and we now have a real way to solve this exact diagnostic dilemma. We are finally shifting away from that old traditional empiric treatment model, the one defined by indiscriminate PPI use and massive overdiagnosis. Instead, we are stepping into modern management. It's sleek, it's highly precise, and it is phenotype-driven and evidence-based. And phenotype-driven just means we're looking at the specific observable characteristics of the patient's actual condition, rather than just taking a wild guess based on a generic symptom. We demand evidence first. So how do we get that evidence? Through this highly specific three-step algorithm. Step 1, objective testing. We stop just asking about heartburn. We actually look inside. We measure the acid. We test the motility. We get hard, undeniable data. Step 2, individualized treatment. Once we separate the true pathologic reflux from those functional imposters, we can tailor the therapy exactly to that specific patient. And finally, step 3, selective procedural intervention. Surgery is now strictly reserved for the folks whose objective data absolutely proves they're going to benefit from it. It's just a perfectly logical, systematic flow. Which brings us to a quote that really anchors this entire explainer. The source material states it perfectly. Modern GERD management has evolved toward a phenotype-driven and evidence-based strategy. This just cements the absolute necessity of a tailored, objective methodology. The whole era of treating every chest pain with a blanket acid reducer, it's over. Telling the difference between true disease and a functional mimic isn't just some academic exercise. It literally dictates the entire trajectory of how we care for that patient. So, I want to leave you with one final, vital question based on everything we've looked at today. If escalating acid suppression offers little benefit without actual, measurable pathologic reflux, when a patient presents with these super common complaints, are we actually treating the disease, or are we literally just chasing the symptom? The modern paradigm demands that we stop guessing, we start testing, and we finally understand exactly what it is we're treating. Thank you so much for joining me for this explainer. I really hope this structured look at the data empowers you to think a bit differently about clinical problem solving. Keep learning, stay focused, and I'll catch you guys next time.